morning, everyone. So one more time. Good morning, everyone. All right, thank you. So I want to take a ride with you this morning, and an experience that I've had over the last few weeks, particularly in hearing the voices of some case managers and how they are helping individual patients in getting access to genomic and precision medicine. But I want to just start to really just kind of set a framework of where we are. So some of us can look out at the Capitol down there. So I want to be very clear as a federal employee that this is my voice. It's not the voice of the National Human Genome Research Institute. It's not the voice of the National Institutes of Health. And it's not the voice of the Department of Health and Human Services. As an intramural researcher, I'm sharing data from my research program and sharing my perspectives. So, where are we today? We are at what I describe as one of the most exciting times in the history of science. I've had the opportunity to be at the National Human Genome Research Institute for the last 16 years. When I arrived at the National Human Genome Research Institute, the Human Genome Project was not complete. I arrived in 2002. It was clear that the end of the project was there. The draft sequence was published in 2001. But we were just beginning this ride that we've been on for the last 16 years. This ride of learning about our genome and its importance in our health, but also our importance for our society. And so if we think about where we were in 2002 and the cost of the Human Genome Project, and what is the cost today to have your genome sequenced, we have seen this dramatic reduction in the cost. We've also seen this great increase in the number of individuals who have had their genome sequenced in research and now in clinical care. But it does raise the question of where do we go from here? One of the slides I'm sharing with you right now is showing research articles. You can see with this research article that the orange line is the increase in articles that have been published in genomic, in precision medicine, and the green line in genomic medicine over the last 30 years, and continue to see this dramatic growth with regards to these articles that are published that are research. But we're moving into clinical care. So when you look over the last 4 years and the number of new drugs that have been approved by the FDA and the number of those drugs that would be described as precision or genomic-based drugs, the numbers have increased, and the percentage of all drugs that are being approved by the FDA that are within the scope of precision medicine has increased dramatically over the last few years. So the question of access and accessing precision medicine. So you're going to hear a number of quotes today from case managers talking about their experience with individual patients. But we thought this quote from a board member of the AMA was also an important one to share with the group today. And this is what was said. Many patients do not have access to precision medicine because health insurers do not offer coverage for genetic and genomic services. As a result, access to this next generation of clinical testing service is often limited. So I argue that's the conversation for us today, is how do we think about the barriers in access, and what are the solutions to those barriers to increase the access to patients in need of these types of services and treatments. So our study that Gwen started to share with you is a study to explore the experiences of individual patients that are seeking support and help from the Patient Advocate Foundation in getting access to precision treatments. And what is their journey and what are the challenges that they're having to get access to those treatments? This study, we interviewed 8 case managers who are involved in the genomic or personalized medicine line of treatment for PAF. And we listened to them with regards to the experiences that they've had with regards to assisting patients. And then we took 300 cases that were handled by those case managers and analyzed the data to understand better differences with regards to the population involved, issues with regards to what were the specific barriers for those individuals, and what are the challenges that they are trying to grapple with regards to themselves and their families. So let me just share with you some data. So, patient demographics. Of those 300 patients that we reviewed their cases, the majority of them were female. And then when we look at it from a racial and ethnic background, it's an interesting population. And this is a theme you're going to hear through my talk, is that the vast majority of them are white, with 8% or near 9% that are Hispanic Latino. There is a case manager that has a very focused targeted population and speaks Spanish and works with that population. And then we see with African American, it's approximately 5%, and Asian population is approximately 5%. So let's talk about age. So you see here that the majority of the individual's age is over 56, okay? Now, one of the interesting things about the data is when we think about genomic and precision medicine, there are a variety of areas where the growth with regards to precision medicine. But the real leader is in oncology. And all of the cases that we reviewed were for cancer treatment. So when you look at the age, it makes sense from the perspective of that these are ultimately patients that are seeking cancer treatment with regards to their needed healthcare services. We also looked at income, and I want to talk about the income issue today because I think it was one of the areas that became so clear to me. I heard it from the case managers, but it became clear when we looked at the data that when we look at the income, there's some really interesting things here. You see here almost half of the individuals that are seeking access to care make more than $72,000 a year. Let me say that again. More than half, close to half of the individuals that are seeking access to care make more than $72,000 a year. And what that says to me is that this is not just a problem for what we describe as the traditionally underserved. It is a problem with regards to access for populations across this country who would be described as middle income. So the most common patient diagnosis, as I stated, they were all cancers, but the top cancers were lung cancer, ovarian cancer, and breast cancer, where the patients were seeking access to treatments to support their disease. And you see the top 10, these are the top 10 diagnoses for the individuals who were seeking care for the genomic line. So we have a word cloud here. There's a question that we were able to look at of what was the main reason the individual patient was seeking access. And so we're using this word cloud to help us understand what were some of the main barriers for the individuals. And you see the number one was insurance. But you see some other things that are interesting there around debt, education, insurance status, a variety of things that were important with regards to the barriers in access to care. So we went through the data to try to identify some major themes related to barriers in access to care. And I want to just highlight 5 of those themes that we're seeing in the data. And I just want to back up for a minute and say, this is preliminary. We just completed the interviews within the last month, and we're just now really getting into the data. So this was kind of just the first glimpse of the data, and then we will be going back to really to go into it in much more depth. But based on that first review, these are the major 5 themes that we identified. Off-label indication not approved. Necessary pharmaceutical prior authorization approval not obtained. Medication is not on the patient's insurance formulary. Inability to afford care because of the copayment. And claim denied because of experimental or investigational drug. And so these were themes that came across with regards to the barriers in access to the genomic medicine treatments that patients were seeking support and help from PAF. So this question of the underserved community, I think, is part of the conversation I hope we have today. And our traditional definitions of underserved. So when we think often of traditional definitions of underserved, we're focused on income and socioeconomic status. We're focused on education. We're focused on racial and ethnic minority populations as our traditional underserved populations with regards to healthcare today. But I think the one message that I want to just make sure everybody leaves here with from the data as we looked at it, we actually have to look at this very differently. And when we think about underserved communities and genomic medicine, we have to expand that definition. And we have to expand and think about those barriers to those communities that are traditionally not perceived as underserved. Clearly, issues of rural communities is important, but we heard interesting comments with regards to cultural issues, with regards to unique populations and differences in access, and the barriers that what I would describe as middle-income America has in accessing precision medicine. And that we have to think about those communities also, but then we also must think about the communities that are not even getting access to PAF. And so their voice is not there at all. And I think there's a recognition that we must have that middle-income America is having barriers to accessing genomic medicine when they need it. And then the traditional underserved community is not even at the table. And so how do we grapple with that from a policy perspective to help to both enhance the access for middle-income America and get access to the traditionally underserved? So let me share with you now some of the voices from our conversations with the case managers that gives you this glimpse of the experiences of the patients. As we stated, we try to use the case managers to actually get the voice of the patient. And so let me share with you some quotes. The number one barrier, I would say, is insurance. Not what to cover it, and can and will, but the general consensus is my insurance company won't pay for this, but my doctor says I have to have it. My doctor didn't mention this to me, so I don't want to go and do something he doesn't want me to do. Patients are afraid to make their doctors upset because then if they discharge them from their practice, where are they going to go? It was an interesting theme that we heard of the patient doesn't want to do anything that the doctor doesn't want them not to do. And if the doctor is not proposing the potential of a clinical trial or sequencing of the tumor or anything that may be beyond the traditional treatment, what is this patient to do? I can't imagine anything worse than realizing or being told that the only medication that could cure you or even get you comfortable, you can't have. And the question of experimental treatments related to research and off-label use of treatments was an interesting conversation I had with case managers, where there's clear evidence where a specific drug would work with a specific cancer, but it has not been approved for that with the FDA. And so therefore the insurance company will not cover it. And so this question with regards to access from the perspective of new treatments and how does the individual patient receive this was a theme that we heard. We talk about personalized medicine all the time. I don't think people really have a good grasp of what that means to them. A theme of the interviews was education. Education was a major theme with regards to the challenges and barriers and how do we grapple with that and the requirements of education. So I have a couple quotes related to clinical trials. One of the things we're really interested in with this project is, are there ways that PAF can work with the clinicaltrials.gov? Are there strategies that we can to give more information to individuals who are seeking out clinical trials? And we wanted to explore what's been the experience of individual patients in talking about clinical trials with the case managers and getting access to clinical trials. Some people have this mentality that a clinical trial, they're a lab rat, and they don't want to be a lab rat. Part of the problem of clinical trials are seen as the last resort. If the patient's doctor is saying, well, I have a treatment, and the patient doesn't necessarily think a clinical trial is the way to go. And so this question of knowledge about clinical trials and the potential benefit of clinical trials. Doing the genomic testing on every cancer isn't being done today, which is a detriment when you're trying to look for a clinical trial, because so many clinical trials now have to have a specific marker, genetic marker. If you haven't ever had the tumor tested, then down the road, that could be a delay in trying to get in any kind of a clinical trial, too, because you just don't know. So I asked questions about what are the policy issues that we need to grapple with as a country. What are some of the major issues? And I divided this into two sections: the health policy issues that really frame around issues of importance of how we're engaging with CMS, the role that Medicare has in really setting the policy for all types of private insurances, and the need to really grapple with those issues, and then the issue of education. Education of insurance companies, education of providers, and education of patients. And that we must move forward in a way to address barriers by addressing education. So This is from a new study that was just published showing the growth of genomic medicine for rare disease, for cancer, and combined. And you see this growth is continuing to increase. So we're really just at this beginning. And so thinking about this from a policy perspective, what can we do today to actually reduce the barriers, recognizing that the barriers exist, and recognizing that there are only so many case managers out there at PAF and at other organizations across the country that can help people. How do we get individuals access to genomic and precision medicine when they are in need? So I'm going to end and talk about case managers for just 1 minute. I have 2 quotes. And the first quote is this: most of the time, they tell us that we're their angels, that they don't know what they would have done without us. This issue of how someone has an advocate or someone to support them or someone to help them, that these case managers are making a difference in the lives of individuals. And I want to thank them, the ones that are in the room, and if they can share with the ones that are not in the room, that this perspective that patients provided, that they are angels helping them in getting access. And this last quote from a case manager: when we have a genomic care case, it has taken more than a couple days. We have to check the obituaries before we call them. That's humbling a lot of times. And a lot of our patients die before they get a decision. I never experienced anything like that till I worked here. This is an important job, and it's a challenging job of helping people in need at a time when they seek and need access and treatments that can actually cure or potentially extend their lives. But if they can't get access to it, their lives end. So I will end with this slide. It's a slide that I use often. It's a slide that's one of my favorite slides. It's a picture I took. But I share it as a path and a journey. And if you look off in the distance there, you see a divide in the path at the end. And I see this slide as a metaphor of where we are right now. We are all on a journey, an exciting journey of taking a new science and providing it to patients in need. But there's a path and it divides, and not everyone's getting access. And I argue that part of today's conversation is how do we extend along this path together to make sure that more people can get access to treatments that they need. Thank you.